Hi, thank you for having me today. My name is Kayla Lashinger, like Dr. McFarland said, and I'm one of the new genetic counselors here at Fixel, and I'll be the main genetic counselor for Huntington's disease clinic. So looking forward to meeting all of you in clinic one-on-one. And for the portion of my talk today, I'll be discussing genetic counseling and testing in Huntington's disease at our clinic. And I'll leave some time at the end of my talk as well for any questions, but feel free to put them in the Q&A as I'm speaking. So I'll start with an outline of what my talk will be discussing today. And the first topic that we'll get into is some background information on genetics. And then I'll get more into the role of genetic counselors in HD as well as our specific clinic flow. And then talk about genetic testing indications and some uses for that. And then some specific case examples and unique scenarios that often come up. So we'll start with that genetics background information. And so our body, it's made up of trillions of cells, and within each of those cells, we have our DNA. Our DNA is made up of these sequence of letters, A, C, T, G, and those all wind up into structures called chromosomes. And we all typically have 23 pairs of these chromosomes and small sections of that chromosome. So if you look on the yellow, that white section we can consider a gene. And these are like the instructions in our body, very similar to if we're making a cake and following instructions in a recipe, except instead of a cake in this instance, our genes are the instructions for our body to function, grow, and develop. And our genes, they also come in pairs. So one copy typically comes from mom, and the other copy comes from dad. And we have over 20,000 genes in our body, and one gene in particular is this HTT gene, also called the HD gene, as Dr. McFarland had mentioned. And we do know that certain changes in the HTT gene cause Huntington's disease. HTT, that gene, is found on the short arm of chromosome 4, so this upper section here, on our 4th chromosome. And it provides instructions for making a Huntington protein. So if the typical instructions for HTT say, add 1 cup of flour, in HD, instead of having just 1 cup, you have a repeat of that 3-letter sequence of cups. So instead of add 1 cup of flour, we have add 1 cup, 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 cup of flour. And instead, in our genetic code, instead of having cup, we have a repeat of CAG. And so you have the more CAG of these 3-letter repeats than we typically should. And so that's why you might hear the term triplet repeat expansion disorder to describe HD as well. And so there's different categories when it comes to the number of CAG repeats in HD. Within the 9 to 26 CAG repeat range, we consider this to fall into the normal range. So this means that there is no personal risk for Huntington's disease symptoms in that individual person and no risk for expansion. And expansion means that that repeat size increases to a size which would cause HD in the next generation, so when we're having a child. But in this range, there's no risk for that for the person to have symptoms or for expansion to future generations. The next category, we call this intermediate risk range. So this is when someone has 27 to 35 CAG repeats. And in general, we say that there is no personal risk for Huntington's disease symptoms, but in very rare cases, there have been some individuals who have symptoms and fall into this range. In this range, there's also the risk for expansion in children. And so that risk for future generations to have an HD causing change. The next category is when someone has 36 to 39 CAG repeats, and this is the reduced penetrance range. So essentially, this means that some people, but not everyone, will develop symptoms of HD. So there is some personal risk there. And then there is that risk for expansion in children as well. And then the final range is the full penetrance range, and this is when someone has 40 or more CAG repeats. And in this category, someone would develop HD symptoms in a typical lifespan. So we say until age 80, but that can range past 80 as well and can still develop. With this category, we say that someone will develop symptoms, but we can't predict what those specific symptoms will be, nor how severe they would be or the rate of progression. But in general, we can say, however, that the CAG repeat size and the age of onset inversely correlate. So in other words, the higher the repeat number, the younger age that the symptoms start for individuals. And in cases of 60 or more CAG repeats, that's when we see juvenile HD with the childhood onset. And then just like a recipe where there's some leniency, and if you add a little extra flour, your cake might still turn out fine. This is kind of the same case here. And so in particular, that reduced penetrance range, if you have a little extra flour, sometimes people don't develop symptoms, or if you have a little extra CAG, some people don't develop those symptoms. And with the HTT gene, we do know that is involved in the health of our neurons, so part of our nervous system. And when that CAG repeat is under 35, there's a typically healthy neuron. But when that CAG repeat number is increased above 35, there can be neuron degeneration, and then we can see this contribute to the symptoms of HD that we see. Huntington's disease, it is inherited in autosomal dominant manner, so that means that someone only has to have a change on one of the two gene copies in the HTT in order to have HD. And so this means that the child of someone with HD, they have a 50% chance of also having that same change in the HD gene, but also conversely, 50% chance that they don't have that genetic change. And so if you look in the visual here, light blue with the plus are those who are gene positive, and then the dark blue are those who are gene negative. And so there is an independent risk for each child to have the gene positive change. And so it doesn't mean that half of all children will be positive, but that 50-50 chances for each pregnancy. And if someone doesn't inherit that gene change, then they can't pass on what they don't have. So it essentially ends HD in that line of the family, and no one would be gene positive on this end here. And I also mentioned when looking at those CAG repeat sizes, expansion, and a concept related to that is anticipation. So this is when that CAG repeat number expands from one generation to the next and typically causes an earlier age of onset. We do most often see this happen when it's passed from a male parent or a father to children, but it can also occur with females as well. And so in other cases as well, that number can stay the same or in rare cases become smaller actually. But on average, when it's passed from a father to child, we see that CAG repeat number increases by about 4. And then when passed from mother to child, it increases by 0.2 or would stay the same typically. And then we can also see that younger age of onset when it's passed down through generations. So next, I'll move more into genetic counseling and what we do and why it might be helpful for you or your family members to meet with one of us for HD and how our clinic works as well. In general terms, genetic counselors, we're healthcare professionals. We're trained in medical genetics and counseling, and then we review genetic information and risks based on your family history, and then explore those impacts and emotions related to genetic testing with you, as well as helping to interpret and discuss any results related to genetic testing. So for HD, there's several reasons that someone might see a genetic counselor, which we'll go through in the slides coming up. But this might include predictive or confirmatory genetic counseling and testing, as well as risk management and assessment that's completely unrelated to genetic testing as well. So it doesn't have to be exclusive to genetic testing to have genetic counseling. And there's also prenatal genetic counseling and testing. And this is not something that we do at our clinic, but is available for HD. So we'll start with predictive testing. And this is genetic testing for those who don't have a concern for Huntington's disease symptoms at the moment. And within our counseling session, regardless of the indication, we often discuss personal risks and benefits from testing. And so some of the common potential motivations and benefits for testing include for life planning. So for managing finances or making career decisions, as well as family planning. So for those who are planning to get married or having children, they often seek out genetic testing. And then also the benefit for the personal need of wanting to know and then relieving some uncertainty. Some of the potential risk or perceived risk of testing include stressors within relationships. So this might be within oneself as well as friends and family, and then even in the workplace or the greater community as well. There can also be some difficulty obtaining or retaining insurance, but there are laws in place that are designed to protect against that, which I'll talk about a little bit later as well. And then there can still be some uncertainty even after genetic testing, so we cannot definitively predict the age of onset nor the severity or types of symptoms. And then in that incomplete penetrance range, there can also be some uncertainty that follows with it. And then currently, there's nothing that would alter disease progression before those symptoms have started. And so we like to take it slow through this and really explore that on a person-by-person basis, because once you receive those test results, it's not something that you can unlearn. It's not something that changes in your body throughout your life. And so it's always consistent within you and your cells. And so I want to make sure that you make sure it's the right time in your life and that it's a personal decision that you have no pressure to do at any moment in time as well. And the second category of genetic testing that we think about related to HD is confirmatory testing. So this is for people who are having symptoms of Huntington's disease. And then we'll go through the potential benefits and risks for this category as well. And so some of those benefits include early and appropriate diagnosis. This can help to give a definitive answer and enhance and prolong quality of life for people. Can also give, like I mentioned, that definitive answer. So confirming a diagnosis that maybe was just a suspicion in the family or a thought previously. Can also help to qualify for disability and other assistance as well. And then inform risk to family members. Some of those emotional risks that can come along with testing include psychological burden of now that prior suspicion that was never definitive is now confirmed and is true, not just a thought, it's a confirmed diagnosis. And then there is, again, some of that uncertainty around test results in certain cases. And then the final category of genetic testing is, as I mentioned, something we don't do at our clinic, but we're always happy to connect you with the appropriate counselors. And that's pre-implantation and prenatal genetic testing. So this is for reproductive decision-making purposes for couples who are at risk for transmitting HD. And it can either be done before pregnancy. So this is with pre-implantation genetic testing and then in vitro fertilization, or PGT IVF for short. And so this implants an embryo after screening it and would only implant embryos that do not have the risk for HD. And in certain clinics, it can even be done without that at-risk parent knowing their own HD status. And there's also a grant out there for PGT IVF through a nonprofit called Healthcare HD. The other type of testing is done during pregnancy, so prenatal testing, though it's usually only offered to those who would use this knowledge to make reproductive decisions if they choose to terminate the pregnancy, because otherwise this would take away the child's right to choose and make a decision on their own as they become older. And this can be done either in the first or second trimester of pregnancy with chorionic villus sampling or CVS or amniocentesis. And so this determines if the pregnancy has a genetic change related to HD. And it's also important to consider in this case the implications if the at-risk parent doesn't wish to test themselves, because they could indirectly learn they're HD positive if the testing for the pregnancy is positive. And then in some clinics, they have a less precise option of testing called exclusion testing. And so this says high or low risk for HD, but doesn't give a definitive risk for pregnancy. And now we'll get into more of what our specific clinic flow is like, and which I'm sure many of you have been through, but if family members come into the clinic, this is what they can expect as well. And so we're at HDSA Center of Excellence, and we follow their protocol for testing, especially for predictive testing cases. Because again, we do recognize that genetic testing for HD is simple as a blood draw, but those emotional and psychological impacts are much larger than the simple blood draw is. And so we try to space out our visits and give enough time to think about your decision and answer all of your questions as well. But not every case fits neatly into this mold. And so typically we start with an initial phone call, and it's myself or other genetic counselor, Lee, will call you. And this is mostly just for introductions and to give you an outline of the flow of visits and what to expect when you come into clinic. And then we also discuss the logistics of genetic testing, so letting you know it's a blood draw and how much it costs and how long it takes for those results to come back. And then we also discuss insurance and GINA, which is the Genetic Information Non-Discrimination Act. So this protects employers and health insurance from discriminating against someone solely on the basis of genetic test results. And then in Florida, there is an additional law that protects against disability, life insurance, and long-term care from discriminating against someone. And so sometimes people like to put these insurances in place before they come in and proceed with testing. And so the purpose here is to give you more time to think about all this information that we discussed so that when you do come in, you have questions and we're able to have more of a discussion as well. And then also we recognize sometimes it is daunting for people to pick up the phone and they've been thinking about this decision for a while. And so we want to make you feel as comfortable as possible and know what to expect as well. So this is where the first visit begins. And so this is typically face-to-face, preferably in person, but we can also do telehealth visits. And we do strongly encourage you to bring a support person, preferably someone who's not affected with HD or not a blood relative who is also at risk for HD. And so having that support person really allows them to have a better insight into the testing process and provide you a deeper level of support and understanding of what's happening as well. And so at this visit, your first visit, you'll typically meet with 3 of us. So you'll meet with Dr. McFarland for a neurological exam, Alana, our social worker, and then myself or Lee for genetic counseling. And so we do always encourage a neurological exam, even if someone doesn't have any symptoms, concerns at the moment, but we do this in order to have thorough assessment in case anything does come up on exam. And then in the genetic counseling portion, we will get more detailed information on your family history as well as more information on yourself, and then discuss more of those personalized impacts and emotions related to testing for you. And then if testing is something that you feel you're ready to do and move forward with, we can have you sign the informed consent and submit that sample for blood draw for the genetic testing. And those results usually take a couple of weeks to come back. Then after that, we have visit number 2. So this is also face-to-face, preferably in person, but again, can be telemed, and then strongly encourage you to bring that support person, especially for this visit. And this is really focused around giving those results of the genetic testing. So it's with Dr. McFarland and or one of our genetic counselors, myself or Lee. And so we outline what this means, what the testing showed, and then how you're feeling after the test results and any questions that you have. And then if you're up for it and it's appropriate, we can discuss clinical trials at that time, but then we coordinate a follow-up call or visit with you in the future. And so we really do emphasize that we're all part of your team here to care for you, and this is not where the line ends. We're continued support for you. And so with that follow-up call, it's usually one of our genetic counselors checking in with you about 2 weeks after that results disclosure. And so answering any additional questions you have, if there's anything else you need assistance with, and getting you more support and resources. And then you'll continue to follow with our clinic and all of our wonderful team here. So we have all our rehab team, we have psychiatry as well, and neuropsych evaluation, and the neurology, social work, genetic counselors. We're all here together as well. And then finally, I'd like to go through a few considerations with some case examples with some common questions that do come up. So the first case example I'd like to discuss is related to changes in repeat size. And so common question that might come up is, my mom's genetic testing showed 44 repeats, mine showed 43 repeats, and my sister's showed 46 repeats. Why is my repeat number lower than my mother's, while my sister's number is higher? And so to answer this, we often talk about increasing of CAG repeat size from generation to generation. But as I mentioned, in certain cases, particularly if it's passed from mother to child, we can see that repeat number actually stay the same, and then in rare cases decrease in size. And so that's independent again for each child. And so it wouldn't necessarily change the same amount for someone and their sister. And another consideration is that genetic testing, it's precise to plus or minus 1 repeat. So it gives you a range. If your mom's genetic test results showed 44, it could truly be 43, 44, or 45 repeats. And then if yours showed 43, within that range, it could be 42, 43, or 44 repeats. So that's also something to keep in mind as well. Another case example that could come up is if someone has a lack of family history. So nobody in my family has Huntington's disease, but I have symptoms of Huntington's disease. What could explain this? So there are several things that could explain this. So the first that it could be is that this is the first time in the family that the CAG repeat number has expanded to be large enough to cause symptoms of HD. In that people in your family might have had a large expansion large enough to cause HD is another consideration, but it might have not been identified for various reasons. So maybe somebody died at a younger age and they would have developed symptoms, or maybe other family members fell into the reduced penetrance range and never developed symptoms. Or maybe people developed symptoms that were very mild and misdiagnosed, or undiagnosed is also a case that could be possible. And then another consideration is that if testing has not been done, that maybe this is not Huntington's disease, but instead what we call HD-like conditions, which can present very similarly, but they're caused by different genetic changes. And then we often have questions about testing minors. So parents are often saying, I'm worried about my children's risk for HD. When can I have them testing? And so our general rule of thumb is we don't do genetic testing unless there is a strong suspicion of juvenile HD on neurological exam. We do, of course, understand that it's normal to worry about your child. And so even if we don't have an indication for testing, we can still have them come in for a neurological exam just to have some peace of mind or some direction about their behaviors that are of concern. And so also another consideration is a lot of times it's related to behavioral and school problems that parents report. And so thinking, is this related to HD or is it something else that neurological exam can help? And then children might experience behavioral problems just because, one, maybe they're children and that's how they react, but also differences in dynamics at home. Maybe the differences in dynamics when caring for a family member with HD, or them having their own anxiety related to their risk for HD. They're more than welcome to come in to our clinic and also have genetic counseling if they have questions about their own risk and future options, but we typically hold off on testing until at least 18 years old. And why do we not do predictive testing for minors? So there's several reasons for that. One, it takes away their right to choose. And so again, this would have no medical implications, and so it wouldn't change anything when at this age unless they're having symptoms. And then that also leads to potential discrimination if adoption is relevant, as well as in future employment, school, and our insurances as well. And so I'll leave you all with this last slide about more places to find information. One of those is the National Society of Genetic Counselors Find a Genetic Counselor page, and I can post that link in the chat once I'm done speaking. But this is helpful to find a local genetic counselor if someone's not in Florida or near US as well. And then, of course, our clinic website, and then some support organizations, HDSA, the Huntington's Disease Youth Organization as well, and then honestly HD are some ones that are out there. But I appreciate having the opportunity to speak to you today, and I will check the chat if there's any questions at all.